Hi guys, sorry I wasn't able to make it to campus today to go over this lesson with you. This is for lesson 10, and so we're going to be talking about interventions, and there's a lot of content to cover in this particular lesson. So what I've done is I've divided it up into 2 weeks. So we'll cover the first part this week. We'll have an application of some of this content from the first part on Thursday, and then next week we'll go over the second half of the content, and then similarly have a application of that second part on Thursday's class. And then we're pretty much done. I think we have a final exam review the following Tuesday, and then we're into final exam period. So it's really just flown by. All right, so here's our learning objectives for today. So we're going to, define what do we mean by intervention. It's another one of those fun health promotion, health education terms that can mean a lot of different things and is kind of thrown around a lot. We're going to talk about how do we design interventions? What are the steps that going through that? And if we can identify, if we cannot identify a health intervention program that we are either to just, adopt, basically just say this would work well, it meets all the criteria, or one that we can just maybe tweak a little bit. Essentially, we go through some of the steps to kind of walk through, what do you need to consider when there is no solution already out there that you can adopt or adapt, and you have to design your own intervention. Okay, so just to kind of revisit, this should look familiar. This is the generalized model of program planning. And where we are kind of in this process, I think I mentioned this in the first lecture, Health Promotion 410, so this class, we cover essentially, let's see if that cursor is going to work, right? We're going to cover essentially the first two, and maybe we're going to start on interventions, and then when we meet again in the spring, we pick up kind of midway through this intervention step and we follow it through all the way to evaluation. So we're finishing 410, finishing this semester. We're starting to kind of move in to start talking about, all right, what are the steps that are involved in actually developing the intervention. So once your goals and objectives have been developed, planners need to decide on the most appropriate means of reaching or attaining those goals. And the goal is to design an intervention or activities that are going to permit the most effective and efficient achievement of whatever outcomes that you had set. And just as a reminder, these terms are commonly used, but it's easy to forget what they actually mean. Effective means, when an intervention is effective, it means it's leading to whatever desire, whatever your goal or objective is, that it's achieving that. Efficient just means that it's using, making the best use of the resources that are available, and that could be time, money, energy, all the things that are going to be required to do an actual health promotion intervention. So let's start out with some basic terminology. What exactly are interventions? Informally, we define them as the planned goals and objectives that are designed to meet the program goals and objectives that are referred to as the intervention, right? So it's the things that we're going to be doing. A more formal definition that you could use would be that they are planned actions that are designed to prevent disease or injury, right? Or promote health in the priority population. And when we say priority population, what we really mean is just the specific population that we're focused on, that we're interested in targeting or treating for this particular intervention. Oh, sorry about that. I don't know why that came through. Really weird. So anyway, let's go through all these and I'll tell you what these mean. So essentially, this is an example. Okay, so say, for example, your goal is to have the employees at the company that you are the CEO at to increase their use of safety belts when they're riding through these company-owned vehicles, right? And so some intervention strategies that you could use, you could say, all right, well, let's do this $10 incentive that when we see an employee and they're wearing their safety belt, we're going to give them $10 extra on their next paycheck. We could say we're going to go more for the policy level, and we're going to institute company-wide policy that says, all employees must wear the safety harnesses or safety belts when they're in company-owned vehicles. The consequences of not doing that are such and such. Or we could decide, we're going to distribute some educational materials about why it's important to wear safety belts. You could do just one of these, right? You could say, we're just going to do the $10 incentive. You would call that an intervention. You could do all three of these or more of these, and you would still call that an intervention. So intervention is this very broad term that can mean, something that's very simple, like one activity, or it can mean, hundreds of activities that are going on. Okay, so some more terminology. There are many different types of activities that planners can use when they're developing an intervention. And most activities can be replaced in these larger categories called strategies. And we're going to talk about strategies next week, or we're going to talk about the CDC, the way that the CDC defines intervention strategies. They kind of put them into these different categories. So we'll talk about that next week, but just to kind of give you a preview and to know what I mean when I talk about strategies. They are kind of the general plans of action for affecting a health problem. These are essentially your methods. So you may want to communicate something, educate, you may want to motivate people, whatever it may be. Within that strategy, you can have one or more individual activities. Sometimes these are called tactics, right? So just some more terminology to kind of be aware of. All right, so this era of Public Health 3.0, what is this Public Health 3.0? It really is this kind of term that it actually has kind of developed, I would say formally, since I've even finished my PhD program. I think that the general premise of what it's all about and the importance of taking these recommended strategies has been around and kind of the undercurrents of public health for a while, but officially and formally, I don't think this has become like a term since I actually finished my PhD program, which was not too long ago. So what it is this, this idea that we should focus on a collaboration process across sectors so that when we're thinking about problems, public health problems, we've talked about the social ecological model, right? We've gone through examples of how, what determines your eating behaviors, right? And it's not just your individual preferences, but when you think more broadly about it, you can see that there's all these connections between, the different levels of this social ecological model that all are going to have this compounding effect and play this role in what actually goes into your mouth, right? So essentially that's all this Public Health 3.0 is saying, that we need to think about systems. We need to think about that social ecological model when we're trying to help design interventions that are actually going to have significant impact and lasting impact. So public health departments should, when thinking about this, they should partner with public and private sectors, so education systems, government systems, nonprofits. You want to partner with people that are working even in corporate industries, local businesses. All of those should be involved in when you're thinking about a relevant public health problem in your community. Okay, so this is essentially the CDC 3 buckets of prevention. And what they're trying to kind of say is that there should be some more overlap. So you see that we've got this bucket: increased use of evidence-based services, this traditional clinical prevention, this innovative clinical prevention, this total population or community-wide prevention, right? And that is where essentially we have public health is over here, we've got healthcare over here, and then you can see that we definitely have some overlap between these two. This is another one from that same paper that's kind of showing the evolution of the profession of public health over the years. And we've talked a little bit about the history of public health in this course and other ones, but that, the late 1800s, early, the 1900s, all the way to 2000 was really when we saw those incredible gains in public health accomplishments, and we saw that our life expectancy as Americans really improved significantly from 1900 to 2010. And a lot of that had to do with improvements that were made as part of the public health practice, right? So you can see that Public Health 1.0, we had a lot of growth, a lot of new knowledge, new tools. 2.0, these are a little bit arbitrary on the dates, but they're saying it began in about 1988. That was when the Future of Public Health report came out. We started to think more systematically about the development of public health, as a collaboration amongst departments across states. Okay. Again, going along with that, the focus really was more limited to traditional public health agencies and programs, so like public health departments. Public Health 3.0 is the evolution of that with the recession and the Affordable Care Act and the 2012 Institute of Medicine's for the Public Health report that came out, and is exactly what I just talked about, engaging multiple sectors and seeing it as the systems approach to resolving public health issues and not just in isolation as public health entities. So where do we start? There's no one best way to intervene to accomplish a specific program goal that can be generalized to all priority populations in every situation. As you guys know, each population is unique needs, and you can't just copy and paste many times an intervention that worked well with a different population in a different situation and expect that it's going to work in whatever your priority population is. Despite that, there are some attributes that are common amongst many successful health promotion programs. So we're going to list them here. The first is that they address one or more risk factors of the priority population. So targeting just one risk factor has really limited impact, is what we have found. And obviously, if we target more risk factors, it's going to involve more money, more time, more energy. It's much more complicated for evaluation, for planning. It complicates everything. But at the same time, the outcomes have shown to be a lot more promising. Another characteristic is that it's driven by theory. It is based on the best possible evidence, or what we call evidence-based practice. It adheres to professional ethical standards. Okay, so they adhere to professional ethical standards. They are culturally appropriate. They are consistent with professional criteria, guidelines, or codes of practice, and they use resources efficiently and include an evaluation component. And last but not least, they support community initiatives and getting buy-in from the overall design. So we're going to come back through some of those in more detail as we kind of go through this process. So there are three possible routes. When you're a planner and you're faced with this, okay, we have to design this program, we've identified that there's a need in a community, this is a specific population, this is the specific behaviors that we need to target. You've got three potential routes. After you've done all that, you've done your assessment, and then you've got your written your goals and objectives. The first is that you can adopt an existing intervention, right? So this is one that it's used elsewhere. It's been found to be effective. You're going to be working with a similar population in a similar setting. So this is the easiest, basically cut and paste solution to your problem, right? This is what you want. This is what you want to find, that there is an quick and easy solution for this. Very rarely will you be able to find this because the populations are very different and health behaviors are very different. So there's a lot of factors. So very rarely does this happen, but we'll go through the steps and kind of determining whether or not that's an appropriate course of action for you guys. The second option is that you can adapt, which is essentially exactly like it sounds like. It's taking an intervention that has a lot of promising characteristics. It's evidence-based. It's determined to be effective. You may be using a similar setting or maybe a similar population, but not both. And you figure, you know what, it wouldn't take that much. We could slightly adapt this particular program, and I think that it would work, or the evidence indicates that it would work in our particular setting, in our population. If neither one of those scenarios is possible, you're left with the third strategy, which is essentially to kind of design a new intervention. It's not really starting from scratch, but in many ways you might be kind of doing that when you're building it from the ground up. So a word of caution, and this sounds so silly to even say this, and you're like, well, why would we do this? Why would someone do this? But believe it or not, it happens all the time. So when you're designing a new intervention, you really want to make sure it's based on sound rationale and it's backed by evidence, right? You don't just do something because it sounds good or that the planners feel that it's going to work. And especially with smaller interventions with smaller pots of money, this happens so often where, you know, and you kind of understand why someone may, like a school teacher, right? Like, for example, I managed a grant project where we gave $10,000 to elementary schools across White County, and they got to implement these interventions that would help their students to increase physical activity in their schools. And so many of them were just things that sounded good, or that seemed to work. And when you think about it, these are school teachers. They're very, very busy individuals. They don't really have time to go and do. They're not trained to do all this type of evidence-based searching to find the intervention that's going to be most appropriate, right? So it sounds good, or they feel it's going to work. So it really does. It happens all the time. And this just says, many times people are looking at short-term opportunities or short-term goals, and they really don't take that full, because it's time-consuming, right? And depending on the setting, you may not have the time to do that or the energy to do that. So adoption, let's go through the 3 different options to adoption. Simply is kind of a copy and paste. You've got to have a lot of criteria that are met though. The first question you should ask is whether or not an intervention already exists. And if that's the case, you can adopt it. And for program planners to adopt a program, there are several questions that must be able to respond with, a definite yes, that this criteria is met. Those questions are, first, is there sufficient evidence to show that the intervention has been successful in dealing with the problem in question? Obviously. The second question is has there evidence to show that it's been successful in the population that is similar to the one that we're working with? Okay. Is there evidence that it's been successful not only in the population that's similar to ours, but in a setting or more than one setting? Okay. Are there similar resources in the new setting to ensure, fidelity of the intervention? Fidelity just means, are you being true to the intervention, right? Are you adhering to the actual true intervention components? And then fifth, is there a new environmental setting similar to the environmental setting and defining the evidence? So basically saying, is the environment, the overall environment similar, right? So if you can answer yes to all those questions pretty definitively, then you can adopt. However, if any of the answers to these questions is no, then you're going to have to consider either adapting or developing a new intervention. Adapting, and I put this picture here because I thought it was hilarious. Like, not all adaptations are, safe. So if adopting an existing intervention is ruled out, the next is, can the intervention that was successful in another setting be adapted to work in the new setting? How do we do this? Well, the CDC, along with some external partners, have developed this kind of model that provides some guidance on how to adapt evidence-based interventions. It's a framework, and it kind of builds upon the expertise, it relies on it. It's a general strategy, but it's relying on the people who are actually doing the intervention. It requires that they have expertise, not only with the priority population, but they understand the community, they understand the health behavior. So essentially, it's a 5-step approach. It's represented graphically in kind of this linear form, but like most of the models and the frameworks that we have gone over in this course, it's one thing to represent it one way, very nice and neat and tidy, on the slide, and say this is how it works in theory, but in practice things are a lot more messy. It's an iterative process. There's a lot of back and forth. So this is the figure. This is figure 8.3. It's a map of adaptation processes, a systematic approach for adapting evidence-based behavioral interventions. And you can just kind of see, it's pretty intuitive, right? So you're kind of starting where you're assessing, you're selecting, preparing, piloting, implementing. I just want you guys to we're not going to practice using this or anything, but I just want you kind of to know that there is some guidance out there to kind of help you, guide you through that process. It's not just, okay, adapt it, right? There is some guidance, and there's other ones out there too, but this is the one that I think is probably most widely used in the field right now. So my question is at what point does an intervention become something new rather than an adaptation? So you have to consider, okay, if this original program had this, and this, then if we cut this and cut this, is it an adaptation or are we doing something new? This is a really funny video that was sent to me, and I can't play it on here because the copyright will pick it up when I upload it to YouTube, but I would definitely recommend checking it out. And it's like, okay, this is Batman, but is it really Batman? You know, at what point does it become something completely different, or at what point is it an adaptation of it? All right, designing a new health promotion intervention. So when you can't adopt and you can't adapt, you got to design something from scratch, right? And there's no one prescriptive formula for, okay, this is how you do an intervention. However, there's some questions that planners can ask, you know, obviously in coordination with their planning team and their community members that are designed to kind of help guide the process of creating these new interventions, so you're not completely in the dark. So those are, one, what needs to change? Where's the change needed? At what level of prevention will the program be aimed? At what levels of influence will the intervention be focused? What types of intervention strategies are known to be effective in dealing with the program focus? Is the intervention an appropriate fit for the priority population? Are the necessary resources available? Right, pretty straightforward. And last but not least, would it be better to use an intervention that consists of a single strategy or one that is made up of multiple strategies? And usually the answer to that is multiple strategies, but there are definitely trade-offs. So first and foremost, what needs to change? And of course, you're going to return to your needs assessment, right? And you're going to determine, all right, well, what do we determine were the needs? And what do we determine were the risk factors? And go back to the second step in the general planning model and say, okay, what do we determine to be our goals and objectives based on that needs assessment? Specifically, you want to really focus on examining the behavioral and environmental risk factors, because these are the things that we can modify, right? There's going to be some genetic components that put someone at risk for, say, heart disease or cancer or whatever the outcome is, but those usually are not modifiable. So for our cases, we need to address the behavioral and environmental risk factors. Okay. You also need to think about the context in which a proposed intervention will occur, and this is sometimes referred to as what we call the settings approach. And settings approach, not really such an important term to be aware of, but the things that you're going to be asking yourself is, okay, who's there? You know, how do people in this setting think or operate? What are their social norms? Are there hierarchies of power? Are there accountability mechanisms? Are there any relevant moral, political, organizational cultures or norms that you should be thinking about? You know, what about the broader socio-political and economic context as well? So lots of things to think about, right? But you do need to be sure that you're thinking through those things. You want to address, are you going to be worried about designing an intervention? Oops, sorry. That actually should be the second one. That should be question number 2. What level, right, of the intervention going to be at? So primary prevention, secondary, or tertiary prevention, these were terms that were introduced in the first half of the semester. And I'll just kind of briefly go over them here, just to kind of remind you. Primary prevention is essentially an intervention that is designed for individuals or populations to identify risks or reduce susceptibility or exposure to health threats. So essentially it's like, we're going to try to prevent exposure. We're going to try to prevent the risk factors from even, you know, developing if they do develop, if it's not like a genetic risk factor. Secondary prevention are those interventions that essentially are designed to detect the disease or the problem behavior early and then prevent it from progressing further or from reoccurring. And then tertiary prevention, those are ones that, you know, usually the incident or the disease or the injury or whatever it is that you're trying to prevent has already happened. And then you're trying to simply just kind of reduce, you're trying to alleviate the effects of the disease or injury. You're trying to help, you know, improve recovery time or minimize the effects of of the actual experiencing that injury or that outcome. And this is just an example. This is from Child Protection Services. So example, things like primary prevention would be interventions that focus on the root causes of child protection, so things like reducing the likelihood of abuse, neglect, exploitation. Secondary prevention looks at specific source or threat of a child who is identified, so basically those kids that are at high risk, they might intervene. And then tertiary is kind of reducing, like this child has already been abused, unfortunately, and we're trying to minimize the ramifications of that and prevent it from affecting their adult years. Okay, so what levels? Planners need to decide the level or levels of influence that can best obtain the goals and objectives of the program. And of course, we've said it over and over again, you want to target multiple levels if you can. This approach has trade-offs. It's more expensive, it's more complicated, it involves more resources. So it's not just, let's always do this. You have to always weigh the, what your budget and your resources can afford. Oh, excuse me. So this is an example of doing a multi-level intervention, and the example here is focused on preventing youth substance use intervention. It's a youth substance use intervention. That's really hard to say. So, for example, if you were doing this and you were trying to target all these different levels, at the individual level, you might work on helping the youth develop social skills, personal skills. At this kind of family level, you might focus on building the bonding relationships between the parents and the child, or helping parents to kind of gain the skills to talk to their teen about these substance abuse issues. If you were to also intervene at the school level, you might want to focus on working with administration and changing certain school policies, or looking at peer-led interventions, getting students to lead interventions that might help youth that are at risk for substance abuse. Community level, you might think about forming coalitions, youth coalitions. And then societal might be things like mass media, or what we call big P policies, so policy at the state, the county, or the federal level. Okay, step 4. What types of intervention strategies are known to be effective in dealing with this program focus? What does the evidence show about the effectiveness of various interventions, right? So this is where you're like, okay, what is the evidence base? What does this look like in practice when you're trying to find the evidence-based or the evidence-based strategies? So basically strategies that have been shown to be effective. It's going through a process of decision making, and it's based on the evaluation of reliable data and previous work to help planners in identifying the best available evidence. There are many criteria, or what else word that I'm looking for? There are many standards that you can use to kind of quickly and easily categorize evidence into different, levels or of quality of the information that you're getting. The one that we're going to use in this class, we're going to talk about, is developed by Brownson, and essentially what they're doing, before I go there, let me just kind of go back and explain what this is. Decision making, this is a figure that they use in their article as well, that talks about decision making in relation to deciding how to design an intervention. It takes into account it's a little bit of, right, what does the evidence-based research say? What are the population characteristics, needs, values, preferences? What kind of resources do you have? And then it takes into this big, overarching, what is the environmental and organizational context? So I thought that was just a good visual to kind of show your decision making. It involves all these things, but it may involve them to varying degrees depending on the situation. And then this is just showing quality of data, right? And this is pretty obvious. Scientific literature, basically any of the peer-reviewed data, public health surveillance data, and then we have qualitative data. Those are all going to be more valid than things like, personal experience, word of mouth. It's not like those things are not valuable or useful. You just have to decide what weight that you have to give those pieces of evidence when you're making these critical decisions. So going back to the Brownson article, what they have done, let's see, first of all, look at this. When you're thinking about scientific evidence, there are 3 different categories. So the first, type 1, is going to look at, it's basically information that's going to tell you the size and the strength of the preventable risk disease relationship. So basically, this is the etiological. This is saying, does eating a high-fat diet cause, heart disease? Does smoking cigarettes lead to the development of lung cancer, right? Usually this is done in a clinical setting or controlled community setting. An example would be smoking causes lung cancer. So that's the one kind of type or category of scientific evidence that you would look at. The second one would be kind of these initial studies that have been published that are saying, all right, we're developing this new intervention, we're going to test it, right? So these would be usually interventions that are done in tech groups, or they can be done for an entire community. An example of this would be price increases with a targeted media campaign, reduce smoking rates. And then the third type of kind of evidence that you might look at might be evidence of basically published studies showing how effectively or how well or effectively that certain interventions have been able to be adapted, right? So this is essentially a type of data that's showing, it's a study that says, all right, here's an example where we tried to apply this evidence-based program to this different population, and this is how well it went. So for example, an example of this would be understanding the political challenges of price increases or targeting media messages to particular audience segments. All right, so now we're finally getting to the categories, the Brownson categories, okay? So the first is evidence-based. This is a peer review that has been done. This is basically a systematic review or a narrative review of several different studies that have come together, and they said, okay, this is all the data that we pulled together from these several studies, and this is the outcome. So examples for data sources would be the Cochrane reviews, narrative reviews, or community guide. One step down from that are effective, and those are like any kind of peer review article that's been published. So articles in the scientific literature, technical reports with some peer review. One down from that would be promising. This is essentially a program evaluation, but it's not been published in the academic literature. It's not gone through the peer review process. So this would be things like state or federal government reports, conference presentations. And then the lowest category is called emerging. So it's, the least solid, secure option, but it's emerging. This is ongoing work, practice-based summaries, evaluations of work in progress. So pilot studies, projects funded by health foundations, things like that. So those are the different levels. Okay, step 5. Is the intervention an appropriate fit for the party population? Each party population has certain characteristics that impact how well it's going to receive an intervention. And when you're thinking about how good of a fit it's going to be, there are 3 things that you might want to think about: tailoring, segmenting, and cultural sensitivity. And actually, we talk a lot more about these next week when we go into a bit more detail on one particular intervention approach, which is social marketing. But we'll just kind of briefly mention the terminology at here. Sorry if those text messages are coming up. Tailoring. Tailoring is defined as any combination of information or change strategies that is intended to reach one specific person based upon characteristics that are unique to that person. So essentially tailoring is, you're designing something, you're designing an intervention that is going to be uniquely tailored for that particular person. And the rationale is that research is going to show that people who pay are going to pay more attention to information that is personally relevant to them, and which makes intuitive sense, right? Segmenting, kind of the same thing, but it's looking at these are the different segments or different categories that fall within these different segments that you have identified. Segmentation usually involves that there's more than one. And then you're going to tailor to each of those segments. Cultural sensitivity has to do with designing or modifying your intervention to be acceptable to the people that you're targeting, so that it will fall within what they call a cultural framework of the population to be reached. You have to be very careful when you're doing this. Cultural sensitivity is very, very, very important, but you need to be careful not to perpetuate cultural stereotypes, and there can be a fine line with that, but something to be very mindful of. 6 is pretty self-explanatory. Do you have the resources? And 7, right? Would it be better to use an intervention that consists of a single strategy or one that's made up of multiple? And of course, we've said this over and over again. The more levels that you can target, the higher the dose that you can target, the better off you'll be. 2 specific terms that are relevant for this. Multiplicity is simply a term that refers to the number of components or activities that make up the intervention. So you're going to do pamphlets, you're going to do this $10 incentive, you're going to do a policy, right? Interventions that include several activities are more likely to affect the priority population, which I've already said, right? Dose refers to the number of program units that are delivered. So for example, you're going to offer, you're going to do the $10 incentive for people that are in your company that are seen wearing a safety belt while operating a company vehicle, right? How many times are you going to do this, right? Or how many times did the PSA run on the particular channel? That has to do with dose. That's what they mean by dose. Sorry. All right. Last but not least, a systems approach just essentially refers to kind of things that we've talked about earlier, is really focusing on involving community partners, and it not just being like, we're going to involve the public health agencies, we're going to involve industry, we're going to involve education systems, we're going to involve government, we're going to like bring in as many relevant organizations and pool those resources and talk about developing solutions that will be sustainable. Systems approaches are most appropriate for what we call addressing what we call wicked problems, and that may be a term that you've heard before. What are wicked problems? Wicked problems are those that are typically intertwined with other problems, so such as poverty, racism, social determinants of health. Wicked problems, by definition, rarely, if ever, have any kind of formulaic solution, like A plus B, you're going to get C, right? Health promotion frameworks have not traditionally used systems thinking, which is kind of surprising, but they really haven't. And so we really need to start developing these new models and frameworks to think about ways to address these wicked problems. So in summary, interventions are those actions that are designed to prevent disease or injury. There are many times an intervention is made up of a single strategy. It's more common and more effective for planners to use a variety of strategies and hit at different levels. And when faced with the need for a new program, planners can either adopt an existing program, adapt an existing program, or when those are not possibilities, develop a new program.